Welcome to PT Microlessons, fast lessons with big impact. In this lesson, we'll explore stroke volume, one of the two components of cardiac output. We'll define stroke volume, learn how it's calculated, discuss the factors that influence it, and explain why it's important for oxygen delivery and exercise capacity. Before we begin, let's briefly review where we are in our Cardiovascular Physiology series. We started by learning that oxygen consumption, or VO2, is determined by cardiac output and the arteriovenous oxygen difference. Next, we learned that cardiac output is calculated by multiplying heart rate by stroke volume. Today, we'll focus on stroke volume, exploring how it's calculated and the factors that determine it. Let's start by defining stroke volume. Stroke volume is the amount of blood ejected by the left ventricle with each heartbeat and is measured in milliliters per beat. In a healthy adult at rest, stroke volume averages about 70 milliliters per beat. Along with heart rate, stroke volume determines cardiac output and plays a major role in oxygen delivery. Now, what determines stroke volume? Well, it is the difference between end-diastolic volume and end-systolic volume. End-diastolic volume is the amount of blood in the ventricle just before contraction, while end-systolic volume is the amount remaining after. So the difference between these two values is the amount of blood ejected during each heartbeat, called stroke volume. Okay, let's first cover a key point. Remember that stroke volume equals the end-diastolic volume minus the end-systolic volume. So to increase stroke volume, we want the ventricle to fill with more blood before contraction and leave less blood behind after contraction. Simply put, more blood in and less blood left behind equals a greater stroke volume. So let's look at the image for an example. It illustrates how stroke volume is calculated. End-diastolic volume is the amount of blood in the left ventricle just before contraction. In this example, the ventricle contains 120 milliliters of blood. After ventricular contraction, about 50 milliliters remain. This is called the end-systolic volume. Stroke volume is simply the difference between these two values. In this example, 120 milliliters minus 50 milliliters equals a stroke volume of 70 milliliters per beat. In other words, the heart ejects 70 milliliters of blood with each contraction. Building on the stroke volume equation, let's first look at end-diastolic volume. End-diastolic volume is the amount of blood in the ventricle just before it contracts. The key point here is that end-diastolic volume depends on preload, which reflects how much blood returns to and fills the ventricle during diastole. In general, greater venous return results in a higher end-diastolic volume, providing more blood for ejection with the next heartbeat. In the next slide, we'll take a closer look at preload and the factors that influence it. Let's take a closer look at preload. Preload refers to the degree of ventricular stretch just before contraction and is directly related to the volume of blood filling the ventricle during diastole. In clinical practice, preload is commonly estimated by end-diastolic volume. As illustrated by the balloon analogy, greater filling produces greater stretch. The key point is that preload is a volume-related concept. Thus, it is improved primarily through increased venous return. Now let's look at end-systolic volume. End-systolic volume is the amount of blood remaining in the ventricle after it contracts. Unlike end-diastolic volume, which depends on preload, end-systolic volume is primarily influenced by afterload and contractility. Together, these factors determine how much blood remains in the ventricle after systole, and ultimately influence stroke volume. Let's take a closer look at the factors that determine end-systolic volume. Afterload is the resistance or pressure the ventricle must overcome to eject blood during systole. For the left ventricle, afterload is primarily determined by aortic pressure, whereas for the right ventricle, it is determined by pulmonary arterial pressure. As afterload increases, less blood is ejected, leaving a larger end-systolic volume. In contrast, contractility refers to the intrinsic strength of the cardiac muscle. As contractility increases, the ventricle ejects more blood with each contraction, resulting in a lower end-systolic volume. The key point is that afterload is a pressure-related concept, while contractility determines how forcefully the ventricle contracts. Now that we've learned what determines stroke volume, let's apply these concepts clinically. Remember, to maximize stroke volume, we want a high end-diastolic volume and a low end-systolic volume. As you'll see, many cardiovascular conditions do the opposite by decreasing preload, increasing afterload, or reducing contractility. For example, dehydration or hemorrhage decreases preload, reducing ventricular filling and end-diastolic volume. Hypertension and aortic stenosis increase afterload, making it more difficult for the ventricle to eject blood, and increasing end-systolic volume. Finally, systolic heart failure and myocardial infarction reduce contractility, resulting in less complete ventricular emptying and a higher end-systolic volume. Understanding how disease affects preload, afterload, and contractility helps explain why stroke volume, and ultimately cardiac output, declines in many cardiovascular conditions. To wrap up, let's discuss one final concept: ejection fraction. Ejection fraction is the percentage of the end-diastolic volume that is ejected with each heartbeat. Unlike stroke volume, which measures the amount of blood ejected with each heartbeat, ejection fraction measures how efficiently the ventricle empties. In other words, stroke volume tells us how much blood is pumped, whereas ejection fraction tells us the percentage. Okay, let's return to the previous calculation that we used to calculate stroke volume. Here you can see that the ventricle fills with 120 milliliters, giving us the end-diastolic volume, and ejects 70 milliliters during systole, which is the stroke volume. Dividing 70 by 120 and multiplying by 100 gives an ejection fraction of approximately 58%, which falls within the normal range of about 50 to 70%.
That's it for this PT Microlesson. Like and follow @PT Microlessons for more fast lessons with big impact on physical therapy topics.